We're turning next up to Professor John Karnon and Mr. Andrew Partington from Flinders University, who will present on facilitating local economic analyses.
I think you're on mute there, John.
Sorry, first one of the day. I was just saying, so I'm going to present the first few slides, then hand over to Andrew, who's going to give some detail on a case study around this concept of facilitating local economic analyses. And really, this concept is around providing tools to inform the design of new models of care that account for the local context. So the next slide is just talking about the rationale for local economic analyses. So I think everyone will be aware of the pharmaceutical benefits and the medical services advisory committees who use economic evaluation on a regular basis to determine reimbursement decisions for new drugs, new medical services. And I guess our rationale is that these methods should be being used in local health services on a more regular basis to justify the implementation of new services, comparing expected benefits with the costs of implementation. But we've got to recognize that just because a service may be justified on economic grounds for one local health service, that may not be that service may not be justified for another local health service because populations differ across local areas. Current practice differs, so current practice may be very good in one area, not so good in another, and so the need for new services may be less in one area than another, and opportunity costs differ in terms of where to allocate scarce resources by different local health services. Next slide, Andrew. So, but I guess the kind of irony is that economic evaluation may be more needed in local health services, but it is more complicated. So we think about new drugs, they're generally simple interventions. We can undertake high quality randomized controlled trials, and that data that we generate is generally transferable across settings. Whereas for health services, the delivery of healthcare is subject to human factors and complexity. Data, therefore, is subject to high risk of bias, and as I've said, it's not directly transferable between settings. And also, in terms of the resources available and the time available to undertake these analyses, new drug companies start early in the development process to consider the economic effects of different pharmaceuticals, and they spend big. The amount of money that is spent to take a drug to market is huge, as we know, and a considerable amount is spent on demonstrating cost effectiveness. Whereas in health services, there's limited internal capacity within the health service to spend time and the effort required to evaluate local services. There is potential to use consultancy services, so we know that local health services do use a lot of consultancy services, and maybe some of that could be used to support local economic analyses. And I've quoted here Andrew, who's controlling the slides here and talk in a minute, who I think encapsulated the problem that we're trying to solve quite nicely. So noting that the methods for economic analyses are well developed and well used in other areas, and this kind of transfer or adaptation of those methods for local health service evaluation is, as he calls it, a normative health economics holy grail. And Bagbanan has looked at this in a lot of detail, working with local health services, and one of his conclusions is that as a decision science, health economics has to work within the context of local health services, which is requiring adaptive decision making within complex systems. So our proposed solution to this is facilitating local economic analysis, and we didn't have to spend too long to come up with that acronym, luckily. And the idea is here that we're working with a particular local health service, Southern Adelaide Local Health Network here in South Australia, and we're undertaking quite a wide range of local economic analyses to address decision problems that Salin have identified. And so our plan is to undertake those economic analyses, but then use the resources that we develop as part of that process to reduce the burden on other local health services who may be addressing similar decision problems. So we're not taking the answers from Salin and seeing if they fit elsewhere. We're taking the methods and the data that we've generated and the processes for generating data with Salin to other local health services to support them in answering similar questions. And the kind of plan is to engage with other local services to use those resources. So my final slide is just to illustrate the examples that we've been looking at. So we've been looking at interventions to prevent a range of hospital-acquired complications, which are top of mind for a lot of local health services, given the financial penalties associated with them. So that's one form of economic analysis where we use local data to understand the problem, but then we look at the published literature and we interpret the published literature in the local context. A second example is extended scope of practice physiotherapist, which is a service that's already being provided in the ED of the Southern Adelaide Local Health Network. And here we're evaluating that service to inform decisions around expansion, contraction, adaptation of that service. But again, the methods, the data we're using can be transferred to other settings. And then the third example is what Andrew's going to talk about, which is an allied health-led assertive case management service to, initially it was set up to manage and prevent long inpatient admissions, but I'll hand over to Andrew to give us some more detail on that.
Thanks, John. So I was just going to say, as a team, part of what we've been trying to embed with the Allied Health Project, all our projects, is this sort of iterative cycle of economic thinking and evaluation. And key to our evaluation with the Allied Health Project has been this concept of a living logic. So it's just something we can pull together that articulates what we understand of as the value of the service, and do so in a way that can be sort of viewed and tested, updated with new information, but then also sort of be retained and referred back to whenever we're thinking about new service improvements. In an economic evaluation context, sometimes we talk about these as being reference models. In other settings, people might know them as like program logics or local guidelines, protocols, even a digital twin. The key concept is we're trying to embed economic evidence within these living documents. And in some ways, this is what one can look like, and this is what we've put together for the Allied Health Project. It follows a structure that a number of you will be familiar with, the PICO, so outlining our participants, our intervention, comparator, outcomes, but extending that somewhat to make sure that we're capturing our understanding about the broader context in which the service is operating. And also importantly, explicitly considering some of the implementation factors with their assertive case management intervention and what that means for the outcomes we might expect. But to get to this kind of understanding, to populate this kind of thing, we've been doing a lot of different analytical, so quantitative analytical modelling beneath that. That we toggle different things to explore the different scenarios under which the intervention might represent value for money. And we have the decision context of saying we'll either implement or don't implement. And if we do, what's our relative values? What are our incremental gains or losses in terms of health outcomes, operational outputs, different financial positions? And we feed that back up into it rolls up into our living logic of what it is the service is trying to do and whether or not they should be implementing or changing their service. But again, to get to this, we've been developing decision trees. So this is a model that follows the diagnostic and therapeutic pathway of patients within the service. And the branches of the tree, a somewhat sideways tree, sort of represent the journey that different proportions of the population take through ward care, additional GEM or HIF care, where they're discharged to. But importantly, we're capturing the outcomes associated with that. So a range of outcomes, just abstracting a couple here. Of course, we talk about averages and totals, but importantly, also the distribution. And this is really important for the teams that we're working with, because they don't often see across the whole journey. They don't understand necessarily the variation that exists within a pathway and the variability that exists across different pathways for quite a homogeneous cohort sometimes. Again, that is kind of built up from other analyses that we do to semi-autonomously mine and link together different administrative clinical costing data sets together. So we use these to prune the branches of our decision tree models. But all of that I've just sort of shown you are backwards looking models. What we really are working towards now are sort of forwards looking models that can tell us what to expect into the future. And that's really what we need to be able to inform decisions about whether to implement or de-implement different interventions. And so we're going through a process of asking them, based on what we know of the local context and the published evidence, perhaps some of Raquel Bookbinder's work on HIF, we're asking them questions around, what are the potential effects across the pathways in the decision tree, along and within the pathways on sort of like cost and readmissions, but also beyond the pathways. Are the pathways susceptible? Are they sensitive to some of the broader context? And we're going through a process at the moment to try and elicit quantitative measures with those. So we've gone, I won't go spend any more time on this, but it's the idea of trying to capture data related to how we understand the system to work and how it could work into the future, and then feeding that data back into the model. So we're updating those decision trees in a very sort of cyclical fashion. Thanks, John.
Very quick summary really is that we believe in the rationale for our work is that local health services have significant scope for the use of local economic analyses, and that's really borne out through our relationship with Southern Adelaide Local Health Network, it's been a fantastic working with them, and there's been great enthusiasm for using economic analyses across the divisions, across the whole network really. But it's clear that there are limited resources to undertake them, and so yeah, so that's our hope, is that by developing and applying the types of resources that Andrew's described and across priority areas for decisions within local health services, we can support increased use of local economic analyses. Yeah, and feedback, suggestions, and especially volunteers in terms of local health services are very welcomed.
Well, thank you very much.